strong honor to introduce our keynote speaker today, Dr. Indu Subramanian. Dr. Subramanian is clinical professor of neurology at the Geffen Medical School at UCLA and directs the Southwest Parkinson's Disease Research, Education, and Clinical Center for the U.S. Department of Veterans Affairs. She obtained her medical doctorate from the University of Toronto, completed her residency at UCLA, and also a fellowship in movement disorders at UCLA. She has a keen interest in integrative medicine, particularly yoga and mindfulness, and is board certified in integrative medicine. She's also passionate about palliative care for Parkinson's disease. She's published extensively on Parkinson's topics in leading journals of the discipline, and she's really one of the leaders in helping us better understand things such as the effects of the pandemic, inequalities in social supports, and of course, wellness in Parkinson's disease. She also updates the public about important topics in Parkinson's with her colleagues, Dr. Michael Oken and Dr. Johnny Geffen, through their online blog, Parkinson's Secrets. Dr. Subramanian is actively involved in various leadership roles, including co-chairing the Wellness Task Force of the Movement Disorder Society and chairing the Movement Disorder section at the American Academy of Neurology. She's one of the few doctors in the world that is trained in both Parkinson's disease neurology and integrative medicine. We're very lucky to have Dr. Subramanian with us. Please join me in welcoming her.
All right. Well, thank you so much for that beautiful introduction, and thank you for the opportunity to come out and talk to you. I'm just so honored to follow speakers like Mike Oken and Bas Blom, who are, world leaders, and sort of humbled to be in this space with, this lectureship. And I think this is such a beautiful gathering, but also I want to commend Dr. Watts for really putting together a beautiful lectureship series, but also really believing in the possibilities of what can happen when people think out of the box to really help people living with this disease and their caregivers and their family, and really change the way that we, really think about this from a multidisciplinary approach. So thank you for having me. Thank you to the Zoota family for supporting this beautiful Parkinsonology, sort of offering, as well as what you're doing here at TCU. And I really, am excited about the future to see kind of where this goes. I am one of the unique sort of trained individuals who, has a real interest in things outside of standard Western care. And I think I'll bring that to you in this lectureship. But I really want to just sort of take a moment, if we can, just to sort of hold space here and look around for a minute at all the faces in the room and think about how we didn't have this for a few years, right? Just 4 years ago, the world changed and we really couldn't connect like this. And now we're in a space looking at each other. It was just really beautiful to connect in person, shake some hands, give some hugs, and honestly look in your eyes. And so I want you to take a moment to do that with each other. Look at the table that you're sitting at. Look at the people around you. And realize that we didn't have this for a few years, right? We were all disconnected. And it's just so beautiful to finally be in a space with each other and support each other. And this is available to you in your community. And Chris has created these resources for you in this space. And so really, I want you to lean on that. So, you have these lecturers that come in. I'm following Bas Blom and Mike Oken, world leaders, but really you have each other in this space and the people that are here in this room. And I want to help you understand that is part of the medicine. So maybe we can just, set the space. We can maybe take a minute, close our eyes for a second, and just take 3 deep breaths together and see how we feel at the end of that. So close your eyes if that's available to you. And let's breathe in together. And exhale. Another deep breath. And let's exhale. And one last deep breath together. And a deep exhale. And open your eyes and feel that stillness and the togetherness. It's really, so powerful. So my topic today is on wellness and Parkinson's disease, and I think it follows well with the other lectures that were given already that are available if you weren't here online. And Chris has a website that he can tell you about that have those lectures. But I wanted to bring you a little bit of a different offering today. And I want you to think a little bit outside the box and go on this journey with me if it's available to you. So classically, Parkinson's is taught with these figures, right? So we think about a motor disorder, and these are the pictures that we teach our medical students around, this sort of stiffness, slowness, tremor. These are sort of the progression of the disease from unilateral symptoms, so one-sided symptoms of stiffness and slowness and tremor, to eventually sort of needing to use assistive devices and things like that. But those of you who are living in this space know that this is not what Parkinson's is on a day-to-day basis for a lot of us, right? So when I take care of Parkinson's patients, a lot of what I talk about in clinic is really the non-motor complex of symptoms. It's not the motor symptoms, which we often have good treatments for, but it's really this whole cascade of other issues, including things like blood pressure regulation, including constipation, things like that, but also a huge mental health burden. And I want you to know, if you don't already, that 40% of people living with Parkinson's deal with things like depression, anxiety, apathy, sometimes cognitive changes, sometimes even seeing things that aren't there. These are things that people live with and are a huge burden, and often people living with Parkinson's don't even realize that this is part of the disease. So that is important to realize. And also, when we look at those figures, I think we are struck by something, right? These are largely figures of men, and they're largely figures of Caucasian older men. So when we teach medical students with these pictures, somebody that looks like me who can walk into a clinician's office with classic signs and symptoms of Parkinson's is told that it's all in their head, that this isn't real, that they can't get Parkinson's, that they need to see a psychiatrist or go to a yoga class and decrease their stress. And we're missing this diagnosis because of the images that we are teaching around this disease. And so we really have to change that. And there are people globally that look like me, that are younger than me, that are suffering in Africa, for example. A huge percentage of patients globally that don't even have access to very basic medicines and aren't getting diagnosed because of the stigma of this disease and how we are using these wrong images to treat and teach these students in medical schools and other places around the world. So we really have to rethink how we're doing this, the image of Parkinson's, and change the fact that we teach it as a motor disease, even though the fact that the non-motor burden is huge. So we wrote this paper on barriers to getting access to mental health care. This paper was written in the pandemic, and when we talk about the barriers, there are many. So things like lack of a good healthcare system and recognition of the disease and the fact that it affects mental health in the first place. We have things like stigma, which I'll talk about in a minute. We have COVID-19 that's really changed the ability for people to connect with each other and has worsened rates of anxiety, depression, apathy in our patients already. So really have to think about who's not being served and what is not being taken care of in your average clinician's visit. And I think we do well with things like motor disorders and the movement part of things. We have medications that treat this well, we have surgeries that treat this well, but this whole area of non-motor issues are really things that we don't treat well at all, and we really need to think about how we're addressing this. So we have these medications, and many of you may recognize this carbidopa-levodopa here, and this is an oldie but a goodie, and it works really well, and I think we need to have access to this drug for everyone on the planet living with Parkinson's. We've been able to repackage this. We've got innovative surgeries that are allowing us to treat the motor symptoms well, but what we don't do well is really focus on the non-motor issues and also help empower patients to live better from the day of diagnosis. And so I want you to think about this a little bit through my journey with you on this talk. So some of you may have Parkinson's, and some of you may take care of people, a person living with Parkinson's as a caregiver, a loved one. But you think about the day that you got the diagnosis. Let's just take a journey back to that day. We ended up talking to a number of patients who were told that they have Parkinson's, and this day was like a bomb went off in their lives. And many of them think that and remember back to that day as the day that changed their life forever. And what they recall from that day is really that they went in to see a doctor and, oh, where are the slides? Is it? Okay. Should I not touch this or? Okay. The day that changed their lives forever. And really, they remember just getting a pill and being told to come back in 6 months without a lot of other information. And because of that sort of sense of not being held, not being given compassion and hope and a plan for what they can do in between that visit to the next and how they could set themselves up, it really derailed them. I don't know if any of you experienced that. Do you remember that day? Or maybe who felt like that was done well? Can we put our hands up? Who felt like it didn't go so well? Yeah, pretty much everyone in the room, right? Yeah. So I think we really need to do better as clinicians and understand that the messaging, that sort of sense of giving you empowerment, giving you a positive sort of space in which to ask questions and feel like you're supported really needs to be changed, because I think that psychology of what you felt that day then sort of leads to how you feel for the rest of often your diagnosis. So I think we really need to do better. And these are some of the things that the patients told us that they were feeling that day. They felt like they had anger. They felt like they were demoralized. They felt like they weren't sure about their future. They were hopeless. They had some grief, anxiety, shock, fear, all kinds of things. They felt very alone. And so I think seeing this for the first time, a lot of our patients, since we wrote a publication about this, and Brad McDaniels, who's in the room, was also involved in this publication, really has let people sort of articulate how they really felt and want to do better for the next set of patients who are to be diagnosed in the future. So I think we do need to do better. And I think stigma is something that is huge. So stigma is something where we feel othered. When we have something like a diagnosis like Parkinson's, you feel different than everyone in society. And we really haven't spent very much time talking about this. We mentioned Africa. In Africa, people think that their family member has been possessed by witchcraft, that there's something wrong with them. They're hidden in the back. They don't get medications. They're really shunned from society. And in some ways, I think in the Western world, we have some of this as well. So we really have to think about how this affects us. And sometimes it's not just that society is treating us differently, but the sense that we feel that society is treating us differently and that we put that on ourselves. And so when we talk about this with some women, for example, living with Parkinson's, they talk about the fact that they're embarrassed, they feel ashamed, they feel like they can't be caregivers to some of their kids or grandkids, and that they really feel like they're not able to because of that lack of being able to really shine in that caregiver role. They feel less than, and they feel sort of, some self-hate and blame. So we really have to address this. We have to say, this is a normal reaction to getting a disease like this. You may go through this sort of feeling of demoralization. You might feel stigma. Let's connect you to other people who felt this way and help you through this time frame. So we don't do this right now, but we're really trying to create resources to do this. And I think sometimes just getting in a room and seeing all the other faces here can make you feel less alone. So stigma is important because it's associated with mental health outcomes that are poor, a lot of other things, poor quality of life, poor self-esteem, feeling like you can't take care of yourself, increased stress, and then social isolation. So really this sort of downward trajectory. So we really have to target stigma head on. And so what we're proposing, even from diagnosis, is really giving people resources in a compassionate way, giving them a sense of empowerment, and helping them with, possibly support and social support like this from diagnosis so that they don't feel alone. So this is something that we're trying to do from diagnosis, and I think we need to think about, how can we do this better? And we're really trying to engage patient voices like yourselves to really do better for the next round of folks that are being diagnosed. So my talk is on wellness, and people have wondered, like, what is wellness? Is that like a massage? Is it some fancy spa? Is it like some yoga clothes and a yoga mat that's expensive? No, I'm going to teach you a little bit about this concept of wellness, and we're really late to the game. If you think about other diagnoses like cancer, like heart attacks, like many other types of diseases, when you go in to a doctor with these sort of symptoms, they give you a package. They tell you what to do from diagnosis. They tell you what the support group is going to be, what your trajectory is going to be. They give you a sense of what you can do every day to exercise or connect with other folks that are dealing with this. And we don't do this in Parkinson's, so we really do have to do better. So wellness is not the opposite of illness. What wellness is the active pursuit of activities, choices, and lifestyles that leads to a state of holistic health. So you as the patient are in control. There's a sense that it's holistic. It's not just about your tremor, it's really about all of you. We sort of have a sense that it's multidimensional, and it's not just about your physical state. It's really thinking about your mental state, even your spiritual state, the environment in which you live. It's really ludicrous to think that a person living with Parkinson's is just their tremor, but that's a lot of what we focus on in that office visit. We don't think about who's in their home to support them, what their community looks like, what their interests are, what their spiritual background is. We do none of that. So I think we really have to really think about this in a very different way. So when we, in the standard Western paradigm, take care of patients, it's really that you come in, you complain of a symptom, I treat that symptom and I let you sort of go loose for 6 months, and then you come back and complain of another symptom. I bill for that symptom and then I give you another medication. It's very episodic. It really puts me as the doctor in control, who you might not even have access to, because many people don't have access to even a neurologist. Believe it or not, 50% of Parkinson's patients in this country don't even have a neurologist taking care of their Parkinson's disease, let alone in many parts of the world. There are very few neurologists in most countries in Africa. There's maybe even one, perhaps, for the whole country. So we really don't have enough physicians taking care of this, which is why we have to really engage the multidisciplinary team. And you are in the best place for that. You're training some of the leaders and the physician's assistants, occupational therapists, speech therapists, all kinds of folks here on your campus to go out and be extenders of our care. So really, I want you to envision a different sort of paradigm, this wellness paradigm where you as the person living with Parkinson's can choose your own sort of outcomes. You are given choices in your lifestyle to do every day to live better with this disease. And we know certain things can help. So we really have to think about not just curing a symptom, but really thinking about you as the person, empowering you with that information and integrating this into your daily life. So I work at the VA. I run one of 6 centers of excellence in Parkinson's. Your closest VA that has one of the centers of excellence is actually in Houston. Are there any veterans in the room? Wow. Yay. Thank you so much for your service. It's my honor to take care of veterans every day, and I really love that population. Thank you so much for your service. So at the VA, we have this, what we call the whole health sort of wheel, and you have this sort of patient in the middle here, and it's a little different, it's a little reinvented from what Bas and Mike had shown you, and I'm going to show you another image as well. But the patient's always in the middle. And then we have these lifestyle choices around, and we're going to touch on some of those. So we reinvented this for people living with Parkinson's, and we thought about, sort of what are the things in the daily lifestyle choices that we can do to sort of help influence Parkinson's patients. So we're going to touch on some of these things like exercise, diet, sleep. I'm going to touch on and focus a little bit on mind-body approaches because that's a specialty of mine. And we're also going to spend some time talking about social connection because that's another passion of mine. But other things that are on here include the cultural context and also this red sun over here that includes the general medical health. So it's, again, ludicrous to think that a person living with Parkinson's is just their tremor. There are many things in your body that can also influence how you do with Parkinson's. So things like bone health, gut health, your vision, your hearing. If you can't hear or see, that can actually put you at a much higher risk for dementia. So we want to be targeting these, making sure that all of these things are well taken care of. Even your oral health, so your dental health can actually influence how you do with Parkinson's. So all of these things are things that we need to care about. So I also mentioned the cultural context. So largely how we've approached things is sort of sense that we have a Western approach for largely older men, but what if you're somebody who looks like me? What if you're a woman? What if you're a person of color? What if you have different religious beliefs? What if you live in a rural area and you don't even have access to internet? We really need to be thinking about customizing our care for the person living in front of us. And I love this cartoon from the First Nations, and their concept of health actually involves the land. It involves their tribe. It involves their tribal leaders. It involves the elements. It involves other tribes. So for me to take care of somebody who is in that sort of cultural context is very different than another person who may not be as part of that. So I think we really need to be catering to the person who is in front of us. And this culturally competent care, I think, has been, we've shone a light on where we have deficiencies in this. I think we really need to be thinking about things like trauma. For example, we saw the veterans in the room, things like post-traumatic stress disorder. Many of you lived through war, you lived through adversity, sometimes in childhood, all kinds of things that may influence how you function when you get a disease, when you're older, when you're aging. Things like, what is your perception of health? Some people feel like they got sick because of something they did. There are religions that sort of have that sort of connotation, and they're wondering every day when they wake up, oh, I wish I hadn't done that. Maybe in a past life I did something wrong, or in this life, things like that. And so that can really influence how you then interact with the healthcare system, how you interact with your own symptoms. Who gives you health and who supports your health? For many of you, maybe prayer is available to you. It's ridiculous for me to think that that isn't important when we're talking about choices, as we're sort of dealing with perhaps end of life or other things. We should be identifying some of this and leaning on those people to really help be part of the medical paradigm. So I'm really sort of open to understanding what spirituality does for our patients, and engaging health leaders of faith traditions to kind of help guide that. So I think, really sort of being a little bit more open-minded to not just the doctor in the white coat in sort of this, clinic setting, but where is health? It's really in the community. It's really in your daily lives. It's really in the patients, the people that you love, the people that support you. So really thinking a little bit outside the box. So I mentioned that we try to get patient voices, and I've been writing some papers with Sonia Mathur, who's an amazing thought leader. She's herself a family doctor who got Parkinson's in her late 20s. She went to medical school in Canada and is a physician there. She's now in her 50s, and she's been writing papers along with other people living with Parkinson's. And so this is a little bit hard to read, but there was a paper that they wrote about what people with Parkinson's disease want. And the types of things that people with Parkinson's disease want are things like access to a movement disorder specialist. That's not really surprising. Care, good care that's community-based. They also want support. So they want support for themselves, and they want support for their family members. They also want information about self-care. They want to know what they can do for themselves every day. They want education about lifestyle choices, guidance on things that they should be doing. And so I think we owe that to them, and we need to give vetted resources. So this is, from the mouths of our own people living with Parkinson's, and I think we need to be guided by this. So we're really trying to get to a place where we're giving bespoke care. So I'm trying to really reimagine the images, and here's an image that we created for a paper that I wrote with a dietitian living with Parkinson's, thinking about protein and how it affects absorption of medication. But I think that the bespoke care is a long time coming. So women, for example, living with Parkinson's, they have a smaller body mass index. They weigh less, right? So when we give them the same amount of Parkinson's medicines in a cookie cutter fashion, we end up causing dyskinesias at a higher rate. And then they end up losing more weight because of the dyskinesias. So we really need to think about, again, bespoke care, understanding who's in front of us. And so this is one of the new images. And then we have been really trying to recreate some of the sort of images around who's not being served. So here's a paper that we wrote on women in Parkinson's and gaps in care. This was in January of 2022 that this came out. It involved 3 women themselves living with Parkinson's that are themselves healthcare providers, and really inspiring to hear from the voices. So again, Sonia Mathur was a co-author, the dietitian Rochelle Flanagan in Ireland, and we had someone from the Netherlands whose name is Annelian Oosterman, who was pregnant with her 4th child, and she's an OBGYN living with Parkinson's. And we tried to ask them, what are the types of things that women are not getting care around? So women have a different phenotype. Even though they tend to get Parkinson's less often in the US, in parts of Asia it's actually equivalent. Women get it as often as men. And as I mentioned, women tend to beat themselves up when they can't be caregivers. So they sometimes tend to take care of everybody else. Are there women in the room with Parkinson's? Can I get a show of hands? Wow, a lot of women. That's amazing. Do you guys have a women's support group here just for women? No? I would encourage that actually. Because women, interestingly, don't fight for themselves, but they fight for each other. So, and women support each other very differently than men do. So often women need another woman to kind of be the person, to kind of be their cheerleader. They're more open-minded to telling that other woman about their issues, sometimes taking another woman in, be it their sister, their sorority sister, their neighbor, their best friend from high school. So really, I think we can maybe think about having, maybe a support group just for women here, because I think it really matters. The issues that come up for women are very different than men, and often women don't speak up. So they tend to minimize their symptoms. They don't talk about the real issues that bother them, and they often sort of are deferential to men. So we don't really get to the heart of the matter. And what I've loved to do, and I don't know if you guys have heard about the World Parkinson Congress, but we've had some women's roundtables, and really it's been beautiful to hear women talking about their problems and having other women really support them. So I think we really need to be doing some of this, because women will take care of their children, their husband, their mother-in-law before they'll take care of themselves, and often then don't come in to see doctors, they don't participate in research, and their diagnoses are often delayed. And they don't get as good care because of some of the psychology. So we really need to be working on that and engaging women and understanding the psychology and really being proactive about this so that you guys get better care. Because there's a lot of you in this room, actually. I don't know if you realized how many women were in here. But I would love to see some networking, too, after this. So, I really want to sort of plant the seed of ideas for you guys to do some of this connecting. We also, in this paper, wrote about the fact that the hormones can affect women living with Parkinson's. So women will talk about the week before they get their period, their motor symptoms and non-motor symptoms get worse. They also talked about the fact that the perimenopausal time, so going into menopause, they felt like their Parkinson's symptoms got worse. The menopausal time, things were hard to control. Sometimes they needed more medication. So we need data on this. And so women getting together, writing this paper, we've already made some sort of headway into getting some things done. So we've created a registry for pregnancy to see what drugs are safe in pregnancy for women. Believe it or not, there are many women around the world that are have Parkinson's that are trying to have babies. And so we need to understand this. They've created an app for women that are looking at hormonal cycles and trying to understand how those impact things. There's some interest in looking at hormone replacement therapy and whether that may be beneficial. So a lot of things going on. And so there are some virtual support groups also for women. There's one of my patients, Twitchy Woman, is a interesting name. She's running a virtual support group out of Los Angeles, and she has about 400 patients that are women from around the world. And there's also are there any Latino populations, Latino women, for example? Yeah, put your hands up. So I'm seeing some nodding, yeah. So there's actually Compe de Parkinson's is a Latino women support group out of Spain. So I think, kind of reaching out to these resources is great, and I would love to see some of that. So coming back to wellness, so really understanding, even in 1977, George Engel wrote about the biopsychosocial model of disease. This is over, I think, 50 years ago, and we have not really applied this so much to Parkinson's. So we know about the biology, right? We know that there's proteins depositing, we know what the symptoms are, but the social aspects are huge, and the psychology of this is huge, and I think we are really sort of falling short of really addressing some of these things. So if you don't have social support, your disease trajectory is very different. And if you don't have coping skills, if you have mental health issues, if you're having issues with accepting the diagnosis and moving forward in a positive way, this can really impact how you're going to do. So I've been a Parkinson's doc for over 20 years, and I've really, can kind of sense from day of diagnosis who's going to do well, and there's a secret sauce. And I don't know what exactly it is, but I'm trying to figure out what's in that secret sauce. So hopefully you guys can help me sort of figure out what the ingredients of that secret sauce is. But I think a positive attitude, having a good social support, trying to get empowered and educated, and you guys are already doing some of that, right? You're already getting some of those brownie points because you're in this room right now. But there are people that aren't in the room. And look around and think about who are the people in this Parkinson's world that you've met that don't come to this kind of thing, that are isolated in their homes. Maybe people that don't feel like this space is accessible to them. For example, there's a huge number of African American patients living with Parkinson's. Parkinson's doesn't discriminate. It affects populations pretty much equally. And yet none of those folks, or very few of those folks, are in this room, right? So we need to engage them so that we can understand for all of us what makes this disease unique and how to really address this. Even Latino patients, many of them are not in the room, but I know that they're in your community. So we really need to get out there and engage people that are not feeling like they can come out like this. So we mentioned trauma. Trauma is something that many of us carry, and there are people who've had tremendous adversity in their childhood. The ACEs, which is the Early Childhood Adverse Events Scale, is something where we look at things like trauma before the age of 16. Did you have someone in your household that was incarcerated? Did you have somebody who was a drug addict? Did you have parents that got divorced? Did you yourself have abuse of some sort in your childhood? In all other diseases, we have a sense of, does this put you at increased risk of getting the disease, and also your trajectory? And it seems to predict how people will do for a host of diseases. We haven't really got data in this, and our group is starting to look at this, and we have started to see that if you had some of these issues growing up, that it does put you at increased risk for getting Parkinson and also for getting more non-motor issues, especially as your disease progresses. And that's not really surprising. Depression, anxiety, apathy. So if you're someone who had some of this, I think we need to be honest. Also, post-traumatic stress disorder. If you went through a lot, perhaps in your service, things like that, we need to be honest about kind of what we're bringing to the disease so that we can really get wraparound care. So we mentioned that I have a background in integrative medicine, and so this is training in systems of care outside of standard Western approaches, and really the sense that we have we can borrow from things like Ayurvedic traditions, traditional Chinese medicine, other things. And I think it fits quite well with the World Health Organization's definition of disease, which is not just the absence of disease, the World Health Organization's definition of health, which in the 1940s was defined as not just the absence of disease, but really this complete physical, mental, and social well-being. So thinking about that as health and not just your tremor or your gait, I think we need to sort of open our minds a little bit. So we talked a little bit about these lifestyle choices, and I want to give you just a hint of a few things I'm just going to touch on, but then we're going to spend a few more minutes on other things. So thinking about what brings you joy and what brings you meaning. Can we bring some more of this into your life? So for some of us, maybe spending time with your grandchildren or your children. For some of you, it might be this, right? So I didn't get the memo that I was supposed to wear purple here. I did wear blue and red, which together make purple. But I'm so in awe of your sports and your sort of love for them. I was in one of the restaurants here last night, watching the Stanford versus TCU game, and it was. I saw a lot of love and connection and passion. So so sometimes medicine is loving a sport with other people and cheering that on. So if that brings you joy, bring it on. So we really want to get back to like what really brings you joy and meaning. What gets your heart rate up in a good way? Where do you sort of find that passion? Exercise is medicine. You heard from Bas and Mike about this. So if you can incorporate this is important. Sleep is huge, so getting 8 hours of sleep is huge. When we've all had a good night's sleep, it's definitely a good thing. Nutrition, so you are what you eat, and your grandma told you that, but like as many fresh fruits and vegetables, Mediterranean diet, things like that. Hydration, you live in a very hot place, I'm realizing. My hair is not very happy here. Drinking as much fluids as you can, keeping your electrolytes up with Gatorade, coconut water, things like that is important because it is hot and your blood pressure can get dysregulated and then you don't feel so well. So I'm going to spend a little bit more time on the mind-body approaches. So I have a background in yoga and mindfulness. I really sort of dived into that as a young mom to help me sort of restore my sense of balance. And when we think about mind-body approaches and we talk about trying to incorporate this in your life, we talk about things like yoga, Tai Chi, mindfulness, meditating on a mat for 20 minutes a day. But that may not be accessible to you, and it may be something that you would never be able to do. So I really want you to take a look at this list and think about things that you may already be doing and how can we incorporate a little bit more. So things like gratitude, things like journaling, things like breath work. So we spent literally a minute together at the beginning of this talk breathing a few breaths, right? And I think we all felt a little bit more connected, a little bit more calm. So there's hugely impactful breathing exercises that can help directly impact the sympathetic and parasympathetic systems, which can be dysfunctional in Parkinson's disease. Getting out in nature. Nature is a huge way to get some mind-body approaches, and it's usually free and accessible to all of us. So getting out in that beautiful campus here, you have beautiful green spaces I saw with lots of purple flowers I saw as well. So I was just noticing all the purple and how you guys have incorporated that here on campus. So gardening, maybe getting out. There's a thing called forest bathing in Japan where they go out in the forest and literally hang out with the trees. Looking up at the stars at night and being around a bonfire, things like that. These are all ways to kind of get into nature. Prayer actually gets you brownie points as well. If you have a spiritual connection and you enjoy going to church and singing with people or praying together, this is actually a place where you can be still and actually can give you brownie points here as well. And then singing, dancing, playing music, art, anything that gets you into the flow state. And perhaps even, I guess, if you're really in the flow state when your team is winning, maybe that also counts. I don't know, we'd have to figure that out. But, looking at this tree of contemplative practices, there are many things on here that you wouldn't expect to be on here. So even getting together and volunteering, social justice causes, places where you really are giving, where you get sort of that sort of extra sort of energy around being connected. These are places where the contemplative practices can show their face as well. So I did this fellowship at the New York Zen Center for a year with 30 other healthcare providers, and it was really amazing. I really have been learning about the benefits of this space, and I, happy to chat a little bit more in the question and answer about this. But I think, these are places where we can all find connection if you can do it together, and stillness. And I think we all need a little bit more of that. So I'm going to pivot to another love of mine, which is really talking about loneliness and social connection. So we published this paper in 2020. This data was pre-pandemic data, believe it or not, in Parkinson's disease, looking at loneliness and social isolation in Parkinson's disease. And just as a background, social connection is a basic human need, just like food, water, and shelter. It is a basic human need. And I think we, in our push as Western society to be independent and not be a burden on each other and really, sort of be able to take care of ourselves, we've sort of got disconnected. And we've also allowed things like social media and Facebook and all these sort of fake ways to pretend like we have a lot of friends to kind of seep in. So I think we really have to get back to basics on how important social connection is. And we have data in general populations that being socially isolated is worse than smoking a half a pack of cigarettes a day or being obese. This is a huge health, social determinant of health, and we really need to care. We have done nothing to really look at this historically in Parkinson's disease. So just to define things, social isolation is something that I can measure. I can measure your forms of connection, who you're talking to on the phone. I can measure who you live with, who you might encounter at the coffee shop or other places. loneliness is a subjective feeling. So it's really this feeling inside that I feel isolated. So this perception that there are relationships that I want and there are relationships that I have, and there's this gap between the relationship that I want and the relationship that I have. And it's that real felt sense of something missing is what we call loneliness. So in doing this research, it's been really interesting and eye-opening for me. So there's various spheres of connection that we need to cultivate. So one is the intimate sphere. So you have that perhaps if you have a care partner in your home, your wife or your husband who lives with you, you have this confidant, emotional partner that lives with you in your home. But we also need to cultivate a relational sphere. So we have to have friends outside of our home that we can kind of interact with. We can talk to as, this companionship of close friends or social companions. We also need a collective sort of sphere of connection in which we have a connection to something, network or community of people who share one sense of purpose and interests. And I think we all know in this room what many of you people here at TCU may have as your collective sphere of loneliness, right? So, but if that doesn't resonate with you, if like football or whatever doesn't resonate with you, let's find things that do. And this is important not just for the person living with Parkinson's, but also your loved one. So caregivers, we see you, we acknowledge that you're in the room. Maybe we could have a show of hands of who are the caregivers in the room. Put your hands up high, caregivers. Big, big props. This is hard work. It is hard work. We don't, as a society, care for our caregivers. You are unpaid, honestly, beautiful humans who are just doing this out of love, right? So, and we see you as doctors. We just can't bill to see you, but we see you. And unfortunately, our healthcare system is not set up to care for caregivers. But if we don't care about you, then who's going to care for our patients, right? So we need to care about this. So everything I'm saying in this talk, actually, is for you as caregivers, as well as the healthcare providers in the room. We all, as healthcare providers, are terrible at doing all of this stuff as well. So we really need to be cultivating a sphere of someone intimate, some friends, and then something where we connect with a higher sort of meaning and purpose. And that's the way that we can sort of satisfy this sort of social connection. And so it is true that you can actually have a married couple that's happily married and very connected, but they're lonely together. And so we need to find ways to connect that couple to other people. And we have to be very intentional about this. So loneliness is bad for the body. It causes stress hormones go up. It causes immune issues. You can get sick with infections and stuff if you're lonely. It affects your cognition. People fixate on socially threatening stimuli. They start to get their circadian rhythm broken up, so it affects sleep. It can really mess people up. There's a reason that solitary confinement is not good for people, right? So many of you may have been solitarily confined during the pandemic, and this is a huge trauma, actually, that we're still recovering from. So really, it can really affect people. So we did a study in which we looked at we have about 2,000 people doing a survey every 6 months. I collaborate with Lori Mishley on this through what was called the CAMCARE in PD. Now it's called the MVP, the Modifiable Variables in Parkinson's Study. And we looked at things that are modifiable and how they impact how people do with Parkinson's. So we were quite surprised in our data set, and this is pre-pandemic data in this paper that we published, to see that loneliness affects quality of life tremendously. It affects quality of life much more than this line that is the tremor line, is the yellow line, and being lonely is the red line. And you can see that it affects quality of life tremendously. And it also impacts symptoms of Parkinson's. So it is as bad for you to be lonely, which is this bar here, as the beneficial effects of exercising 7 days a week for 30 minutes a day is good for you. So exercise is medicine. It's the one thing that we can really do. 7 days a week of 30 minutes of exercising. The benefits of that, if you take a look on the negative side of things, being lonely is as bad for you as the beneficial effects of exercising that much. And so in the pandemic, we were really worried with this data going into the pandemic that we had a population at risk that were kind of derailed from their exercise, and then were worse. We're forced to basically be socially isolated in hopes to not get spread COVID, but we really sort of had a sense of, are Parkinson's patients really being at risk to not do as well in the long term? So when we looked at the lonely cohort, the types of things that they seem to have worse symptoms around were the things that actually are quite impactful from quality of life and non-motor issues largely in mental health. So things like depression, anxiety, apathy, sleep, all of these scores were worse in the lonely cohort than the non-lonely cohort. So very impactful and things that matter. So we really, going into the pandemic, had this worry, and that's why we called our paper the synergy of pandemics. So we had this increasing incidence of Parkinson's globally. You've heard this from both Mike and Bas. We're not 100% sure why. Parkinson's cases have doubled in the last 40 years, slated to double in the next 20 years. This loneliness pandemic that was already present in society before the pandemic, and then enter COVID-19. And the worry was, and this is actually a pictorial by Bas Bloom and his group, of our Parkinson's patients being derailed from things around the pandemic, being socially isolated. The worry was that they would have a downward spiral from social isolation and a lack of exercise. And he proposed certain things right at the beginning of the pandemic that were sort of the saviors of the day, and things that we had sort of been hyping even before the pandemic, things like mindfulness, things like exercise, and things like online social connection. So we really tried to take this seriously and be proactive in trying to connect the community. So Brad and I, Dr. McDaniels and I, wrote a chapter on loneliness for a COVID book on Parkinson's. And we looked at a number of populations around the world, and every population that was surveyed had some worsening of anxiety, some worsening of depression, and some worsening of sleep around the social isolation from COVID. So we really, were worried about sort of a population at risk. And so we proposed this sort of diagram where we have a population at risk for getting socially isolated, enter a diagnosis like Parkinson's, and worsening of things like stress hormones, sleep cascades, and really worsening of motor and non-motor issues, leading to then feeling more need to isolate, getting derailed from things like going out, getting exercise, things like that. So we had this diagram that we put in the paper in 2020, and we proposed a solution which was kind of novel at the time, called social prescribing, and I'd like to tell you about it. So social prescribing has been described relatively recently, and it's this concept that I, as a doctor, can literally prescribe social connection as I would a pill like Cinemed or exercise therapy. So I literally would write a prescription for getting connected socially. So this was talked about in the New England Journal, and one of the first publications around social prescribing was at that time. And it had been in place in the National Health Service in the UK, and really sort of the sense that we are able to kind of connect patients who are at risk or are lonely with things in their community that can be interventions like a pill. So things like gym classes, art-based therapies, yoga classes, exercise classes. So you may know somebody who's doing that here in your own midst, who had shown you a website, right? So Dr. Watts has already put some of these resources together for you in a beautiful way. And so literally, we can hopefully identify people at risk by asking them questions and then being intentional about writing a prescription for social prescribing. So here's a way to find connection, right, for you, many of you. But in the National Health Service, they have sort of this pictorial of a person who might be at risk. And they, in the National Health Service, have folks like link workers that are able to know what's in the community and connect people to things like a gardening group, like a yoga group, like a volunteer opportunity, like a sports club. So you in Fort Worth here have some of these things, and I think we have to be intentional about trying to get you out, maybe catering some of the things to you, maybe a women's group, maybe doing some other things. But I think being intentional about understanding how impactful social connection is, just like exercise is a medicine for you, and trying to be intentional about doing this. And I literally write out a prescription for my vets. I say, go call your best friend once a week. Let's try to get this to happen, right? So at the VA, we took this seriously in the pandemic, and we actually redeployed some of our volunteers, if you've ever been to a VA, when you come in, you're often greeted by a volunteer. All of those volunteers lost that sense of purpose actually in the pandemic. They were told to stay home themselves and they were hungry to try to help. So we redeployed them in this thing called the Compassionate Contact Corps. We had them call patients either through a virtual medium, we gave patients tablets and things like that, or over the phone, and tried to organize sort of a way to proactively reach out to lonely veterans. And so I think we could do some of this and take some sort of use this as an example of what you can do in your own community. So I mentioned, there are people that are not in this room. Perhaps you can think about in your own support groups or in your own life, who are people that are not in the room? Who are the people that don't come to church that used to? Mrs. Smith and Mr. Smith used to be in that pew. I've spoken to some religious leaders. They call it the empty pew syndrome, actually. So it's like, where is Mr. Smith, right? He was suffering from Parkinson's and Mrs. Smith is taking care of him. They can't leave their home. Can we do something to reach out to them? So maybe give them a call, maybe leave them a little note at their front door saying that you miss them, right? So we need to be intentional about this, but really bringing care back into the community where it belongs. So I was very passionate about this. I ended up talking to a New York Times reporter about social prescribing and recording a TED talk about this, because I really, it had taken me 20-something years of my career to realize that social connection and the people around me were part of the medicine, and that really got me through the pandemic, I know. So we ended up arranging a virtual support group from day one of the pandemic, and we ended up recording about 120 interviews with a support group, the PMD Alliance, which aligns in my area. But we really tried to be intentional about connecting people. We had, at times, 1,000 people living with Parkinson's live on Zoom, and it was a pretty amazing phenomenon. So really, tips for clinicians in our paper that we wrote is really being aware of how important loneliness is in health. Screening, so things like, do you sometimes feel left out? Do you sometimes feel isolated from others? These are some simple screening things, and I hope, to create a very small screening, 2 or 3 questions that we can give to all people, not just living with Parkinson's, but all people coming in to healthcare. Because we realize actually that for lonely and isolated patients, the healthcare provider may be the only person that they're seeing at all in their lives, weirdly. This is a weird touch point, right? And I wrote a paper just recently with another colleague around who dies in heat waves. It's a weird question, right? Why do I care as a Parkinson's doctor about who dies in heat waves? It's very hot out there. You guys are used to the heat, right? But like in other parts of the world, if you have sudden heat waves, people die. Who are the people that die in heat waves? It's usually people who are already marginalized, people who are sick, people who are older, people who have had trauma, and then people who fall on the other side of the digital divide. So don't get those alerts. And this, unfortunately, is a lot of my patients. A lot of my veterans are those people. And sometimes it's people who don't ask for help, right? So it's a lot of, weirdly, honestly, the people who die in heat waves are often men, actually, because they don't ask for help, they are isolated, they sort of live alone and kind of doing their thing. So we really need to figure out in our communities who those people are and really be intentional about reconnecting them. So if that's you and you're sort of thinking, yes, I am lonely actually, what can I do? Well, reach out, tell your doctor that this is something that you are feeling. And bizarrely, many people feel alone in being alone. And so they don't even bring this up. And our Surgeon General, Vivek Murthy, has made this a national, health kind of crisis point. And I think there are many Americans living out there that don't have anyone that cares about them or interacts with them. So really being intentional about this. So we have ways through community groups like this, through a social worker, through other folks, sometimes even an allied health professional. If you know an amazing OT in your backyard or speech therapist in your backyard that loves Parkinson's patients, talk to them. See what they can do to kind of connect you with other folks. So really, I think this is like medicine, and we really need to be intentional about this. So the bottom line, social connection. We want to find our tribe, find your cheerleader, confidant. For women, it's going to be probably another woman. I hate to say it, but we need to find other people who can really cheerlead for us, who sort of can see us and we can be honest with. Meet your neighbors, join a support group, you're already doing that here, exercise classes, maybe your spiritual class or group that you have not gone back to after the pandemic. Volunteer. Volunteerism gives you huge brownie points, can make you feel a lot better. And for those volunteers at the VA, they really felt derailed, and reconnecting them to our lonely veterans was a great thing. And so I think, maybe organizing a phone tree even amongst you here, who's not in the room? Can we reach out to them weekly? Can we check in and see how they're doing? Thinking about even online resources, I think one of the silver linings of the pandemic was many of us got comfortable using social media, using Zoom. And so can we, connect on Zoom for reading maybe to your grandchild over Zoom or FaceTime even. And I didn't just talk this talk, I really walked this walk too. This is my family. My parents live in Canada. And in the pandemic, we didn't see them for 2 years. And so we did this weekly Zoom time, and we celebrated many birthdays and had some very beautiful moments despite being separated. And it was beautiful to reconnect in person, but I think these are some memories that I will always have of that time frame that are very beautiful, in fact. And so, reconnecting in whatever way is available to you, and here, you have a tribe, maybe connecting with them. So, can we find joy? Can we find connection in our own backyards? That's hopefully what the message is here. So again, a shout out to the caregivers. So all of this is important. And I think it's really important as caregivers to take care of yourselves. And we don't say enough of this. So again, I want to reemphasize, if you don't take care of yourself as a caregiver, then who will take care of our Parkinson's patients, right? So it's really like that oxygen mask analogy. And this goes for the healthcare providers in the room too. We have to put our oxygen mask on first in order to take care of anyone else around us, because if something happens to us, then that's one less person to provide care. So find your own buddies and tribes, find your own check-in. It's really, I think, a lot about sometimes quality time with our loved ones, not quantity time. People feel guilty about leaving for, maybe a glass of wine with a girlfriend. And that's okay. We want you to recharge, replenish, come back, and be mentally well to take care of our loved ones with Parkinson's. And people who are caregivers are at a much higher risk of many healthcare outcomes that are negative. So if you're in trouble, if you feel isolated, if you feel alone, ask for help. There are resources, certainly at the VA there are. Ask the social workers, and we want to make sure that you're okay and not suffering by yourself. And I think for all of us in the room, I just want to give ourselves permission to not be perfect, kind of let things go a little bit, decrease the expectations. It's okay to sometimes just have cereal for dinner. It's okay to, have a little bit of a, messy car or messy room. I think we just need to kind of give ourselves a break. This has been a marathon, not just a sprint, right? So we want to just give ourselves permission to take a break, get some rest, get some alone time, regroup, recharge, really. So I think it's just so important for all of us living in this crazy peri-pandemic time frame. So I proposed to you a number of barriers to getting mental health care. And I think, getting to the root of what really our hope is, Brad's part of this project, really to think about wellness as a very proactive sort of thing, is to really get people educated. So you're already in the room listening to a lecture like this. But being inclusive about who needs to know. I think everyone in our community needs to know a little bit about Parkinson's. We need to destigmatize this, because many people living with these symptoms don't even know that they have it, because they don't know that they can get it. As somebody who is younger, who looks like me, a person of color, a woman, somebody who's younger, there are many people who don't know that they have this disease. We really need to rethink that. We need to also think about a multidisciplinary approach. It is ludicrous for me as a movement disorder specialist to think that I'm going to clone myself and that there's going to be enough of us to take care of the global needs of everyone living on this planet with Parkinson's. It's just not going to happen. So we need to engage folks like speech therapists, like psychologists, like occupational therapists, like physician's assistants, and give them the tools that they need to help be extenders of care. And then to help them understand who really needs to get to see somebody like me, how often they'd be checking in and things like that. So we shouldn't be fighting in the medical community about who doesn't know what they're doing, but really try to work together to do this better because we have to. There's no other way. We have to empower our patients with teachable lifestyle choices. So we talked about sleep, diet, exercise. Hopefully I've convinced you that social connection matters. Some of the mind-body stuff matters. I hope I've taught you a little bit about that. We want to realign healthcare to your community, and you have a beautiful community of people here. Look around, and you have an amazing cheerleader who's at the helm, who's your dean here. So I want to, really validate that and not make you think that you have to go to the Mayo Clinic to get great care, or to the Netherlands or wherever. It's really happening here in your own communities, and you are a part of that. Every one of you in this room has some piece of that, and I think we want to feel like that is given to you and you're empowered to do that. We have to be proactive, really think about who's not being served globally. I mentioned, the African issues, but even in your own community, even in our backyard. For me, 10 miles away from me, I have, many people that don't seek care because they don't trust the healthcare system, or there's other issues, barriers to care. So who's not in the room? Let's get that sort of going as well. Think about that social prescription. Think about you putting yourself at the helm of your own lifestyle choices and giving you power, giving the power back to you so you don't feel like you're just a passive recipient. So in just wrapping up here, in the quality of life sort of seesaw here, the things that worsen quality of life are things like stigma, loneliness, disrupted relationships, the feeling of uncertainty and demoralization. The things that improve quality of life are things like helping to give you self-efficacy, self-management through this empowerment, this wellness stuff that we've been talking about, building resilience and self-compassion through things like mind-body approaches, and then really social support is a huge buffer for a lot of this stuff. So having people that you can talk to that support you. So the road in Parkinson's is a long road. Many people live many, many years, decades after we diagnose them. I love this disease because of that. I meet people at the beginning and can give them the tools that they need to really thrive. And some of our patients, as Bas had mentioned, the silver lining, that hopamine, they have, be able to reimagine their lives in ways that actually have been better in some ways because they're exercising, because they're more connected, because they're taking the time to really smell the roses, to have, a better quality of life after the diagnosis. But we hope to give you sort of resources along the way, and you have those resources here to sort of handle the roadblocks. So are we able to teach you from diagnosis about these lifestyle choices and how they can make a difference? Are we able to introduce you to the multidisciplinary team that may normally only meet you after you've had a fall, for example, as a physical therapist, or after you've had a choking episode and had a pneumonia as a speech therapist? Are we able to proactively drizzle this in? Can you meet a psychologist perhaps before some crisis happens, or an occupational therapist who might be able to connect you actually as an extender of the social prescribing sort of universe to people in your community? So are we able to sort of teach you about who might be available to you before you need them? And are we really able to do this in a proactive way? So Brad and I, again, wrote a paper about a wellness prescription and really thinking about, things like screening for loneliness at every visit, mental health screen at every visit, checking in about that, looking at things like safety, looking at things like cognition, but really educating people proactively and giving them a sense of social support and introducing them to the multidisciplinary team throughout the sort of trajectory of disease. So really thinking about what we're going to need before the person really needs to engage that sort of multidisciplinary person. So I think that Mike and Bas had talked about their sun and the moon and all that sort of complex diagram. I love this tulip or flower petals here. So we have, again, the patient in the middle and all the lifestyle choices that we have here. And then on each petal, who might be able to be engaged. So we actually have a yoga and Tai Chi teacher here. We have an occupational therapist for maybe intellectual engagement and social connection. We have, religious leaders, and faith-based leaders here. So really rethinking who and how to go about getting care and who might be on that team, and being proactive about it is what we hope to do. So, so just one or two last slides. So in thinking about this, there was a paper just hot off the presses in the Journal of Parkinson's Disease, thinking about, sort of the overlap between physical therapists, occupational therapists, and speech therapists, and really, and psychologists, and reimagining all of these therapists and what they can do. And part of what they can do is actually social leisure participation. So these guys might be an occupational therapist, a speech therapist, maybe extenders of that social prescribing universe. They may be some of the link workers because they know what's going on. So really thinking about sort of a more holistic, multidisciplinary approach. And this paper is entitled Stemming the Tide, the Role of Proactive Allied Health Professionals in Parkinson's disease. And so really thinking about a different way of reimagining this. We wrote a paper on the missing piece of the puzzle, the role of a dietitian in Parkinson's, with Rochelle Flanagan, thinking about things again, culture, behavior change. So thinking about these people that you may normally put in a box to treat a patient only in one way, maybe engaging the multidisciplinary team in other ways to really sort of think more holistically about what their role can be. So as Chris mentioned, we've launched this wellness task force at the Movement Disorder Society, and we're hoping to develop a prescription for living better with Parkinson's that we can give to you from day one of the disease. And it incorporates some of the things that we've talked about today. So we're really engaging people from all over the world in a multidisciplinary team and coming up with what we think could be part of that prescription. And I just wanted to give you just a couple of resources as I'm wrapping up here. So one is the book Together, which is written by Vivek Murthy, who's our Surgeon General, talking about the loneliness part, and also this book by Viktor Frankl, whose work really is amazing to me. He wrote Man's Search for Meaning. I don't know who's seen this book in the room. Has anyone read this book? Yeah. It's a beautiful book, and very short and sweet, but really talking about how we can be sort of our own sort of giving ourselves self-efficacy, the sense that we are in charge of how we respond to things. So everything can be taken from a man, but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. And so that's the hope with getting a diagnosis like Parkinson's. We can sort of help you to sort of cope better and be optimistic and sort of have this empowered, sort of proactive lifestyle choice kind of way. And just to finish here, you've seen the Ending Parkinson's Disease book. I know Mike and Bas had promoted it because they're co-authors, but I think it's a beautiful book. Becoming advocates in this space is so important. I think when you can feel empowered to really make a difference, and this is a picture of Sonia Mathur and some of the other folks that are in the PD Avengers. Many of these folks go to the World Parkinson Congress. There are many ways that you can use your patient voice to really make a difference. And so I encourage you to get involved, find out how to get involved locally here with Chris, participate in research studies. He had mentioned one or two, participating in things that are even on a global scale. So many amazing things, and I'm inspired every day by you, the people living with this disease, and your loved ones. And so that's what brings me sort of my joy and meaning and purpose in life. And so humbled to be invited here, and thank you again for the opportunity.
Okay, thank you, Dr. Subramanian. Wow, that was a really impactful lecture. So much to think about. And I think kind of if we could summarize some of that info in there, I think her pedal slide was a great illustration of some of the core message, right? So she's talking about lifestyle choices, things that you can think about outside of medicine that can actually have an impact on Parkinson's disease, because things like diet do impact the symptoms. Things like sleep do. She talked about the benefits of exercise, mind-body approaches, social connectivity. Now, we brought Dr. Subramanian all the way here from sunny California to even sunnier Texas. And so now is an opportunity for the audience to ask some questions of one of the world's leading Parkinson's neurologist.
And if they also have lost their ability to type on the computer, then they are really isolated. So what do you do then?
Yeah. Yeah, that is a complex problem. And in a sister disease called progressive supranuclear palsy, we have even more speech issues. There can actually, there's the world of speech pathology is amazing. And we have patients that have even been able to use their eyes to find, to be able to use words and sort of almost type with their eyes. So there are some resources that are available that are pretty interesting. Sometimes they can point to a board that has objects on it, depending on their cognition as well, if the eye sort of typing is hard. But there are some solutions that are available. We do use this in progressive supranuclear palsy. ALS is another disease where we use some of these eye things. There are even patients that have transections of their spinal cord and stuff and can't speak, but they're able to use their eyes. So it's a really interesting kind of some of the technologies that we can use. But you're absolutely right. I think being proactive about speech and swallow is huge. And as Chris was saying, even at diagnosis, sometimes there can be subtle things that we can see. There are many proactive approaches that we can kind of engage, and I think we need to be proactive, as we're sort of progressing through the disease, and not just wait until somebody can't speak before we refer. So I think engaging these guys is really important.
How can they get there, and how can they balance all this?
Yeah. No, I think you're right. I think we can make it highly overwhelming, and I have patients who in LA, they have access to things, a lot of means, and I've had patients who are stressed out about getting to the yoga class across the city and then going to the mindfulness class that they think is helpful, and I'm like, you're gonna have to take 50% of the stuff off your list because we can overdo it as well. So I think the goal of the Parkinson's prescription and the sense that you have these choices is really that we can work on one or two at a time. I don't think we want to do everything. I think it can be 100% overwhelming. And I think some of the resources that we give sometimes are so many things. So if you go on, let's say, the Parkinson Foundation website or the Davis Finney, binder of things, it's a lot. And people are just like, I can't even open this because I don't even know where to start, right? Or even as a caregiver. So I think we need to break it down into bite-sized pieces. I also think it's important to make it accessible to everyone. So I think if we make it so complicated or so niche, for example, you need to get on this treadmill at this gym and get up to 80% heart rate on this protocol, it becomes like when people don't have access to it, then they feel bad. They're like, not only do I have a disease, but I can't access the 7 vegetables that on the salad that she showed me, right? The 7 colors of vegetables or whatever. So we need to figure out what people are already have access to and start to drizzle in things that are free or that they're already doing. So, getting in nature, finding friends, somebody who you can connect with. It might be hydration, it might be sleep, these things that hopefully people can start to chip off one by one and start to feel like they're moving in the right direction. But you're absolutely right. I think in a disease where you already come in, sometimes you have apathy or anxiety or overwhelm, it can take a while. And so we need people to really help guide, as you mentioned, a coach. Some folks have actually had peer-to-peer ideas. So for example, Twitchy Woman has mentors. So she's pairing maybe a woman living with Parkinson's who's farther along in the disease than a newly diagnosed person, and having them sort of support each other. So I think there's many ways to sort of think about this. Sometimes a support group leader, it might be a nurse, depending on the practice, or a social worker. But I think it can be 100% overwhelming. And I think you have to be honest about if that's how you're feeling. Like, none of this is going in my head. This was something that we put in our paper about that early diagnosis paper. Some people just need to know what they need to know now, right? And you know what you need to know. If like 50% of what I'm saying is not even computing and you're just like, I'm not hearing any of this, especially on that first visit, The sort of senses that we need to maybe bring people back at 6 weeks, or give them time to digest the first part and then kind of go about more education. So I think giving people what they need at the time and getting that feedback is also really helpful. Some people want to know everything. Some people only want to know what they need to know, and they really don't want to know anything else. So I think we have to sort of, again, be bespoke about what we're doing to the person in front of us. But thank you.
Thank you. You are inspiring and amazing. And so I just have to answer that question and just say, I'm Hillary with Parkinson Voice Project, and there is hope. You have offered so much hope, and I just want to say, for speech therapy, there absolutely is hope. So we treat patients from diagnosis to later on, and it's always better early on. 90% of patients we know will have problems with their speech, and then their swallowing as well. So getting in quickly with a trained speech pathologist is always recommended. We are a nonprofit, and so we can treat everyone in Texas free of charge. We also have groups for the connection that you had mentioned, which is so important. So there is hope.
I'm fascinated with that, wanted to know more.
Yeah. Well, I think that that this is the experience of many women, actually, and they probably had symptoms, and most people with Parkinson's have had symptoms for a while before they present. And the changes that lead up to getting motor symptoms of Parkinson's in many people have been happening, the proteins that are depositing and the changes, so what we call the prodromal symptoms of Parkinson's, for sometimes 10 to 15 to even 20 years before they ever develop motor symptoms. So some people talk about the change in sense of smell 10 years before or 15 years before. Sometimes they'll say their sleep change. So fighting in the dreams, what we call REM behavior disorder, RBD, sometimes 10, 15, 20 years before we get motor symptoms of Parkinson's. Sometimes constipation, sometimes anxiety, depression as a prodromal symptom. So there are things that change in the body before people get motor symptoms of Parkinson's that have been going on sometimes for many years. And then, because women often are not really identified as a population because of images, especially women of color, things like that, we are often told that it's not, it might be in our head, or we can't get Parkinson, whatever. So many women, and I'm gonna ask this as a show of hands, women in the room, who had their diagnosis delayed? Like, do you think? How long? Can you put your hands way up? Yeah, so many women will say that their diagnosis was delayed by a number of years. And even though they were complaining, they really felt like, by the time they got the diagnosis, it was pretty late in the game. The good news is that, right now, with the knowledge that we have, we are able to now diagnose people, through maybe sort of a sense of an imaging study, like a DAT scan, a skin biopsy, these prodromal symptoms, genetic, predisposition and things like that. But we don't have anything that we would have given you as a pill or a surgery or anything like that that we would do differently at the moment with our current knowledge. Even the folks that have environmental exposures, right? We have people at risk, let's say, even Agent Orange. Mike talked to you guys about trichloroethylene, things like that that are in the environment, pesticides, things like that. Even people who are at risk right now, having been exposed to some of that Camp Lejeune, we don't have an offering of a pill or anything that we would do differently. It's really somewhat about these lifestyle choices. So thinking about living better. And so we really want to kind of think about, as populations age, a concept of brain health for the population. So all of the things that I mentioned can be done in aging populations regardless. And it's beautiful that you have your daughter sitting next to you. So you obviously have a beautiful, strong woman supporting you, right? And that's going to be a huge part of the medicine right there. So these sorts of things that we have, good, are we plugged in with good social support? Are we doing these sorts of things? My goal is not to shame anyone and say you didn't do these things for these 10 years and that's why you got Parkinson's, or, you know, you should rapidly, you know, start eating organic, weird, you know, sorts of algae from this river in Tunisia or whatever. Like, that's the kind of stuff that's out there, right? But really, when we're talking about holistic things, it's really about these super basic things, you know, exercise, sleep, you know, getting some rest, you know, unplugging from our crazy lives, connecting with things that matter to you, social support. So I think that, you know, your story is not uncommon, and I think many of the changes have been going on for a long time, but that's not to strike fear in your mind as to like, oh my God, I didn't do all this stuff for all this time. Now that you know that you have it, you have this community, you have these other women that can support you, and I think getting, you know, sort of connected and trying to sort of, you know, work together to build resources in your community so you can really have those folks to lean on, as well as really what my message is to you. Okay. Yeah, we don't have data in Parkinson's to support it. It may be for, you know, certain skin conditions or other things, but hyperbaric oxygen is not, it doesn't have good data to support in Parkinson's progression or prevention.
And the distinction between an individual's spirituality as lived out uniquely as compared with the community spirituality.
Yeah. So very little's been done in this, and Brad and I are also interested in this because I think, you know, as somebody who has, you know, also navigated my own health struggles and with my own family, I think having a sense that you can, you know, focus on the things that you have control over and can give some of your own, you know, disease over to some higher power is actually kind of a beautiful thing. And I've, you know, read some blogs of patients, and people have, you know, been able to tell me about their own beliefs, and I think it's hugely impactful. But, you know, in medicine, I think we've kind of, the sort of pendulum is swung so that when I was in medical school, we were told not to cry in front of a patient, not to talk about things like spirituality, really to divorce sort of that sort of touchy-feely side of things from, you know, the healthcare setting. It wasn't appropriate. And I think, you know, having been a doc for, you know, 20-something years and connecting with people at diagnosis and supporting their families and through until people pass, and I've spent time at the bedside when people are dying and with their families after, how could it not matter, right? The spiritual side of things. I mean, it's a huge, important thing for many people. So I think there's been, you know, religion and religiousness is sort of, you can kind of have scales for that, but then there's also spiritual things and spiritual sort of scales. And I think these are two kind of different buckets. Some people may have sort of an overlap, but there are certainly people who are spiritual that don't have any organized religion, and vice versa, perhaps. So I think we're only now tapping into this a little bit. There's not a lot of information about it. I'm writing a paper with a colleague that's very in touch with this, who's actually a psychiatrist. But I think the pendulum is swinging back to the current state of spirituality in medicine, as written in the New England Journal by, you know, one of the key leaders in this space, is that we, as healthcare professionals, should be able to address spiritual or faith-based sort of support questions directly. We should be able to acknowledge that that is important to the patient. And if it's not available to us or comfortable for us, we should be able to find a member of the team who can then take the baton and go with it. For some of us, it might be a chaplain. But for some of us, it might be us, and we can, I think, be available to the patient. And I think a lot of what I learned in the contemplative fellowship was really about holding space, being able to listen, being able to process what the patient is telling me, even if it's a completely different faith than what I believe in, or spiritual sort of understanding than what I believe in, and then be able to understand what those, you know, sort of values and beliefs might be, and then help guide then what the care could be from there. And so whether that's at the beginning of diagnosis, which we rarely take the time to care about this at the beginning of diagnosis, even if somebody might type, as they're entering your demographic information that you're, Catholic or whatever, that's rarely brought up. Where we tend to care about this is actually when somebody's actively dying and when they may have, weeks or months left in their life. And I personally think that that is a failure of me as somebody to connect with, the person that I'm caring for decades. And so I've been leaning into this a little bit more and trying to understand this. And certainly in the social connection space, being able to connect people with that spirituality to others that may be able to kind of connect with them and foster that sort of mind-body social connection space is actually beautiful, and I think it's been really resonant. But I think medicine is only now opening our minds to being able to even honor this space. And historically, we've really been like, oh, here's a chaplain, have a nice day. Only when we have a chaplain available, which is usually in the palliative care kind of hospice universe. I think way too late, way too little. What's your sense of things? Maybe if I could take a minute to ask you. What is your thoughts on this?
Oh, sorry.
I just wanted to find out what your thought was.
I think that there is a growing reality as people experience a practical faith, not to diminish the mysticism and power of that, but just when we translate it to theological language, we would simply say faithfulness, and how that is lived out in ways that recognize a sovereign God, something greater than ourselves, our responsibility for that which we can do, and an acceptance of one another in that process. I think it speaks to a deep need.
Beautiful. Thank you.
Like I've done my, kind of got you here. You have to go to the rest of the way to stay ahead of the curve, PD.
Mm-hmm. I mean, that's a very complex question, and I think, I usually get that question of like, well, what about the guy who's sitting on his couch eating potato chips and watching, binge watching, I don't know, whatever show du jour. So I really think we have to meet people where they are. I mean, I think, understanding where that mental state of that person is. Are they depressed? Is there something else psychologically that's happened, right? Maybe they lost their loved one, or they just, don't have the means to come. They don't have the money. They don't want to tell you that they don't have the money to pay for parking at the place. But, so understanding what the barriers are and meeting people where they are, I think, once people feel seen and heard, they tend to start to open their minds a little bit. But I think a lot of people are just tired of people telling them what to do. And like, big deal doctors in white coats from blah, blah institution, professor of blah, blah, shows up and tells them, another person telling them what to do when they just psychologically aren't even in the space to care about themselves because of some other thing that we haven't identified. So I think when I have a person who really just is not thriving, trying to just understand, what is it? What is it that you need even to just come into my space and share your story with me and open your mind a little bit, and it might be, not me who cracks that, story open. It might be somebody who is another patient, a support group leader, somebody who looks like them, somebody in their family that may, be able to be engaged to really give me that sort of sense of things. But, I think all of us have a story, and all of us bring, different things to the disease when we get it. And I think, understanding that person and their story and where they are is just a huge part of, I think, getting buy-in to then, and the overwhelm. I think people just see these lists of all this, like every day there's a new fangled vitamin or whatever, or like some cool exercise equipment or some new thing or a new drug that's completely unaffordable, or something like that they don't see themselves represented in that space, and they don't see anyone that looks like them that's talking about this or whatever. I mean, something like that. So I think meeting a person where they are is huge. And I know that I'm just only learning now how to do that a little bit.
Will that be something that looks like baby steps? Just kind of
Yeah, absolutely. Yeah, and again, this sort of, when we look at this flower and the sort of lists of things that I've shown you, right? Like, what are you already doing that we can do a little bit more of, right? So if something that you love, somebody that you love, you know, something that you can already sort of say you're doing, if it's prayer or, you know, dancing with your wife or eating tamales and making them with your grandma or whatever, I don't know, whatever, right? So let's find baby steps and small wins that can kind of get buy-in.
Was abnormal.
Okay.
And the 3 diseases.
Yeah, yeah. I mean, I think we're still learning how to apply this. I think in practical sense of, you know, real time. I personally, you know, was trained to take a history and do a physical exam and start levodopa and see how people respond. I think it gives us a sense of, you know, a population at risk, perhaps with some of the genes that we have, with some of the biopsies, you know, it may give us confirmation, but I don't think that it's hugely going to change necessarily my current practice of how I approach patients. But I think, you know, for studies, you know, there's sort of this sense that we should, there was a paper that came out that talked about doing an imaging study, a biopsy, and a gene test all, you know, on patients to get a sense of like what that shows, and then, you know, deciding what study. I mean, I think that a lot of this is getting more and more expensive, more and more sort of inaccessible for your average patient. And so I think, you know, my sense still is to, if it's available to you, to, you know, go to a neurologist, if possible, a movement disorder specialist, get examined with a history and start on treatment and sort of check in with them and see how you're doing to get a sense of like which disorder it is. I still don't, I'm personally not ordering them quite yet. I think it's still pretty new, and I don't know if it's added value for you guys. It sounds like it hasn't.
Well, one of the things, my wife was diagnosed 2 years ago with either Parkinson or Parkinsonism. She went to 1,000 milligrams on the carbidopa-levodopa, and it hasn't worked very well. She's now nearly 1,500 milligrams of carbidopa-levodopa, and still has some real limitations. And she has all, with the exception of hallucination, if you list all the Parkinson's and Parkinsonism symptoms, she has them all. Mm-hmm. And so trying to sort out where we're going, how we're doing, and we were hoping that would give some clarity to it, and it doesn't appear that it did.
Yeah, I think, again, getting in the hands of a good movement disorder specialist who can spend the time and follow you over time. Sometimes time tells, you know, we sort of follow things, and things kind of, we get a sense over time. It's a very nuanced diagnosis for many of these things, and I know it's frustrating not knowing 100%, but I think at the end of the day, the management of these things at the moment is quite similar. So there's not something you're missing by not knowing exactly which ism it is. We pick symptoms, we do a lot of supportive treatment, and I think, you know, it's probably going to be very helpful for trials down the road to have some of these things just to kind of standardize what we are letting into a trial. Especially earlier on. But I think, you know, right now, again, I'm not using these and I'm not finding them, you know, terribly helpful. And I think, you know, in the hands of a movement disorder specialist who sees a lot of these sort of isms and Parkinson's, it's probably, you know, serves you better to sort of spend some time getting an opinion there.
The healthcare providers in the room could implement, and all of the people in this room could just come ready to their doctor that says, I'm willing.
Yeah.
If they're not asked.
Yeah. So people aren't being asked. People are not complaining of it, and we don't have, you know, I think clinicians are increasingly stressed, and primary care doctors specifically are like, 15 minutes, got to go to the next patient. But you know, when they did studies in the UK, for example, it was something like 50% of visits were around some of this sort of stuff. So people were just lonely, and when you think about who's lonely out there, like, who do you think the people who call us all day that are the spam callers, who are their best friends, right? It's the people who, sadly, are these lonely patients, right? They're like, oh, sure, I'll talk to you about swampland in South Africa or whatever. Like, I don't know, but like, and you know, that is the problem too. Once we start opening the doors, right, to people coming in and online access and things, we really have to be vetting who's touching our patients, because there's a lot of scammers out there. And the number of patients of mine who are at the VA who have like girlfriends in Philippines or where. I'm like, who are these people? And like, you're trying to go to the Philippines to meet this person? Like, what is happening, right? So there are so many people who are kind of, targeting our vulnerable patients. And I, like every time I see a patient, I'm like, okay, like what, so I think there is Brad and I have been looking at there's the original UCLA loneliness scale was like 16 questions or something. There's a modified one that's 8, and then there's one that's 3. The 3 questions, which include the ones that I talk about, sometimes are often feel left out, sometimes are often feel isolated. These sorts of questions, I think there's one other one that I'm forgetting. It takes less than 1 minute. It has been validated on the phone. It's been validated in the pandemic. It's been validated at the VA. So that 3 question is probably very reasonable. And how to bring it up in a healthcare encounter has been interesting because honestly, the way that we start throwing all these questions at people, like I was literally asked if I was suicidal, like by the person who got my insurance information. And then I had to have like a procedure and somebody asked me what my advanced care plan was, like would I want to be intubated and blah, 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 blah. Like it was the same person who took like my insurance card. And I'm like, do you actually care about the answer to this? Because honestly, like we can't just add questions that people who don't care are asking and behave like we're actually doing healthcare, right? I have to ask some of this because I'm the doctor and you have to care that I care, right? That's part of the medicine is if I say out of my mouth that exercise matters or that social connection is a medicine, then you believe it, not if the parking attendant while they're taking your parking whatever money is asking you about your suicide risk or whatever, right? Or your loneliness. Like, but that's where we are in healthcare now. So I think we really have to, I think it's beautiful. You're going into people's homes. That's amazing. You are probably one of the only touch points of that person's anything.
Several times.
Right? And it's a very scary place to be. That's me at the VA, honestly. With a lot of people. There are people that I'm the only one who remembers their birthday and only one who wishes them Merry Christmas. And that's a huge weight, right? So we need to get people, even if it's like meeting the neighbor across the street, right? Or something, but like figure out in that person's home, even if they can't leave, who can come and hang out with them, right? Would you be comfortable with me going across the street and introducing myself to so-and-so, and if they came over and said hello, and you could just sit on your porch and say hello, would that be okay, right?
We have 3 questions left.
Okay.
All right, and so here's the first of the 3.
This is actually a comment and maybe a question. Would pet therapy help?
Yeah.
Would contacting your local organization of Girl Scouts, Boy Scouts for projects where they would just drop in, say hello, bring one of their pets in a bird in a cage, or something, is that beyond really? Just bringing, coming and saying, can I have lunch with you today? Or bringing their drawings from kindergarten classes to the patient. Seems to me that in a community or a neighborhood or whatever, they could be drummed up in some way. I think that my experience with an elderly woman on my neighborhood block, she was cared for by the block of people.
I mean, that's right.
And I think that instigating other people and even children to come in and help from organizations. Thank you.
Yeah. No, I think we have to get creative and inventive, right? We need to figure out what's in your community, what's on that block, what's available, because that's just right. That's sort of, we have to be very intentional about thinking about, and it's going to be bespoke. What works for Mr. Smith is not going to work for, Mrs. Singh down the road. So we have to be really, and I think this multi-generational thing is very interesting. And people have had that as an idea. There's a Dr. Potts, who is a colleague of mine who's an Alzheimer's doc now. His dad passed from Alzheimer's, and he noticed that as his dad was aging, that his art got really interesting. He started getting him to do art. And what they've done in, I think it's like Tuscaloosa or somewhere, and he literally has brought children from the community to pair with a patient who has Alzheimer's or a form of dementia, and their caregiver, and the child, and it's not a small child, but like a teenager, and this couple, they do an art project together. You have a room like this, and you sort of facilitate some art, and then everyone shows each other the art, and they have a dinner at the end. And it really actually teaches these kids, some of whom, like I have, you know, a 23-year-old, a 20-year-old, and a 15-year-old. Luckily, they're close to their grandparents, but many kids are so in their own heads on their gaming and phones and whatever, that they don't even acknowledge when an older person is standing on the bus with them and that they need to give the seat up, like basic things that we all grew up with, right? So we need to give children actually a sense of what it means to be a citizen in their community and to help their neighbors and to connect. So I think that's a beautiful idea. The bird in the cage or the dog or whatever, horses. There are some small studies with this stuff, but I think, you know, you probably know that it helps. So, you know, I think we just need to start doing some of this and sort of see where it goes. But again, I think we just need to be careful with the vetting. So, you know, there are a lot of people who are unfortunately trying to prey on some of our patients. So we want to make sure people are screened well who are participating, you know, aren't criminals or have other, you know, weird stuff. But I mean, it's sad that I have to say that, but that's one thing. But I think, you know, I would love to see where this goes, and Chris will report back to me kind of what the bird in the cage does for y'all the next time. So, yep.
My husband was diagnosed with Parkinson's about a year ago, and in spite of the fact that we're relatively new to the area, we didn't have any problems finding a support system within the Metroplex, thankfully. And I just want to say kudos to the Parkinson's Voice Project. I have questions. In spite of the fact that he has lots of support, family and medical community, I feel alone. So as his caregiver, what I have found is there are no support groups out there. So if there's anyone in the room that knows of a support group, yes, we have family support, yes, we belong to a church, but I feel that what would be best for me is someone else that's walking this path.
Yeah. No, I think you bring up a very good point. There aren't a lot. Jory Fleischer, who is at Rush, I think, or Northwestern, has specifically created programming for caregivers. Interestingly, some of the best people to guide caregivers are people who may not be, they may have had a loved one pass, but they've been through it. They're sort of the gurus of the caregiving space. And some of those people, you know, once their loved one passes, are kind of feeling a lack of, you know, connection and meaning, you know. So I think engaging those sort of folks, if you have some of those folks sort of in and around this community, maybe getting them to come out and sort of maybe be like, hey, would you, you know, teach us a little bit about what, you know, your top, you know, pro tips were or whatever. But I think that's really important, and I think you getting support, and it doesn't necessarily have to be. I think, you know, one thing about the self-care for caregivers, and even these sort of lifestyle choices for Parkinson's patients, it doesn't all have to be so Parkinson specific. I think you could find other sorts of outlets for some of this, even if it's, you know, for seniors or for other disease states, sometimes can also be helpful. So if you're feeling like you have to drive 3 hours to get to your nearest Parkinson support group, but there's a very solid community of folks that are in the geriatrics age at a local, you know, home or something like that, maybe connecting with them. But, you know, I think sort of not being so Parkinson centric, you might find other resources, you know, but I think even online, maybe you could kind of search for caregiver support, and some of the online resources can be helpful. But Jory Fleischer is the person who's doing a lot of this research with her team, and is really, I think, coming out with some good resources. So stay tuned.
I stand less chance of getting Parkinson's. Could you tell me the connection, please?
Yeah, we don't fully understand that, and people have been looking at, you know, once people get Parkinson's, whether to put a try to do a nicotine patch or something, does that change the trajectory? But there are some things that are kind of, yeah, that both nicotine and caffeine intake seem to be sort of things that are protective. for getting it, and we're not 100% sure why. There's some physiologists that have some ideas, but that's not to say that you should go out and start smoking. We don't have that data.
Doctor, we need to pause the questions there because we are at time. I want to thank Dr. Subramanian again for coming here and sharing. From the questions, we know that you spurred thought and that you've inspired people. We've had someone in the back who wants to start a support group for women with Parkinson's. And so I'll be sending an email out to everyone about that. And if you know of other resources that maybe people have asked for here that they don't know about, I have a website. Please contact me and let me know what those are. I will put them up on the website so people can access them and they can find them. It's one of the purposes of that website. Thank you again, everybody, for attending. I'll be in touch soon. Thank you, Dr. Zoota Family Leaders.